lakh workers for health, the mission has been able to add another 1.50 lakh human resources. So really under the mission, the human resources for health, which would include doctors, specialists, Ayush doctors, nurses, ANMs, paramedics, they have been more than doubled. And there has been very impressive addition to health infrastructure as well. More than 20,000 new health buildings have been constructed, which would include sub-centers, primary health centers, community health centers, and also district hospitals. And more than 20,000 health facilities have been renovated and upgraded. So therefore, you know, now you have mobile medical units, which are actually in thousands of them, which are actually taking health services to very remote, inaccessible parts of the country. You have wonderful ambulance networks in place to respond to emergencies, and everybody has seen great success of these ambulances. So a lot of ground really has been covered under the National Rural Health Mission. But I think now a growing concern has been that the same kind of concerted focus needs to be brought to urban areas as well, particularly the urban poor, and that is how this whole concept of an expanded National Rural Health Mission and the National Health Mission, which also caters to the needs of the urban population with very special focus on urban poor, I think is
Ms. Ghosh, should we bring you in here, what are there different problems in urban areas as compared to rural areas in terms of health needs?
Health, not so much urban rural, but like this draft health chapter talks about, it's not so much urban rural as area specific.
Okay.
It's not, if there's a district in Bihar which has Kala-Azar, which is Kala-Azar endemic, it might not necessarily, the divide might not necessarily be urban rural as much as that particular district which needs attention. So to that extent, I think this, rather than the urban rural divide, it's more about customization, absolutely area specific customization, take into account what are the needs, and then you plan from then onwards. You plan your budget, you plan your resources, you plan your everything else, your disease specific programs, everything. It's more like that.
Okay, fair enough. If we look at the urban population, ma'am, you know, I mean, it's 31% of India's population currently. It's increasing rapidly, with almost 5% per year. You know, the increase into urban areas is a huge influx. But are we geared up to even think of, you know, providing health care to those sort of that increase in number?
I think it is quite possible, because as you have yourself said, 70% of your population actually is in villages, right? And the National Rural Health Mission was brought in to address the needs of that huge population. And now what you are actually looking at is about 31% of your total population, which is much smaller. But I think within this urban population, the challenge really is posed by about 9.30 crore urban poor, because you know, within in any urban setting, you know, you have slums and you have a concentration of the poor there, whose access to health care actually is so limited that it is extremely important to try and build up an infrastructure in cities which would cater to their special requirements.
Right, but Ms. Ghosh, would it be fair to say that, you know, healthcare services are only not available to the poor in urban areas? Would you say that, you know, affordable healthcare is really not available to a large number of people in urban areas?
That's the issue. We have somehow very consciously furthered this health apartheid in urban areas, where you have private hospitals dishing out healthcare at exorbitant rates, and then you have a government hospital where the poor is bound to go because they don't have any other option. Now the issue here is that the private hospital that is charging so much, there's a very serious regulation issue there. All the hospitals in Delhi which were given land saying that you will have to reserve 25% of your beds for the poor, these beds are not utilized. They either remain empty, or even when there are patients there, doctors are very reluctant to go there, and that's the reality.
Okay.
So it's something I think the government and everybody else concerned in this, because of lack of regulation, this has it's been allowed to fester.
Okay. Ms. Gupta, then how does the state finance this sort of to bridge this sort of a gap, because their health facilities are available in urban areas, but they come at a cost, and the poorer people would probably have facilities which are somewhat equivalent. Would the state be in a position to finance this?
See, I think there are certain things which we must appreciate. First is that health is a state subject in India, right, and therefore state governments actually remain primarily responsible for providing health care to their populations. I think under the National Rural Health Mission, a major attempt has been made by the central government, to strengthen the hands of the state governments, and therefore more than 70,000 crores has actually been given as federal funding to the states since the inception of the mission. Now the thing is that so far as the rural areas are concerned, we have a very well defined and very well laid out health infrastructure. For instance, 5,000 population, you have a sub-center, and 30,000 population, you have a primary health center.
Right.
Then about 1.20 lakh, you have a community health center, and of course then you have sub-divisional hospitals and district hospitals. But unfortunately, in urban areas, you do not have such a well laid out and defined sort of urban health architecture or infrastructure, with the result that the status of health infrastructure that is available in towns and cities actually varies widely and sharply across states and across cities, because urban local bodies have to play a very major role in providing health care to the urban population. And therefore in Mumbai you would find a particular kind of model or a design, and in Delhi you would have MDC and state government chipping in, and also certain central government institutions. So also mufassil towns where you have say, urban populations. So therefore the position really is, and that is I think where the whole challenge is. Now as Avantika said, I think there is a very interesting sort of this thing. Your 31% population lives in cities,
areas,
but 80% of your private doctors are actually concentrated in cities.
So there you are.
And your 75% of your private dispensaries, are really in urban areas and cities, and 60% of your private hospitals are in cities. So therefore, in rural areas, actually the presence of private players is extremely limited. And when you are looking at remote inaccessible areas where your disease burden is very high, where your morbidity mortality is high, you would find that the presence of private sector is negligible. So therefore what is happening is that in urban areas, access to people is of course much better, but as has been said, I think the whole issue is at what cost, so therefore if there are out of pocket payments involved for people at large, then I think the whole idea when the National Health Mission and extending the coverage to urban population, as I said, with a very sharp focus on urban poor, is how do you make sure that out of pocket health expenditure for this population is minimized, and you have a very strong network of public health facilities, and of course you have private sector for critical gap filling.
So we'll talk more about that, but we need to take a short commercial break. Do stay with us.
For a happy and productive life, one needs peace of mind. That is why I chose LIC. LIC adds some magical notes of security to life. Then why go anywhere else?
घर खरीदना हर एक का सपना होता है। ब्रिगेडियर साहब का भी यही सपना था, पर जब ब्रिगेडियर साहब खुद के घर का पोजेशन लेने गए तो
देखिए, फिलहाल तो आपका घर तैयार नहीं है।
जब वादे हो जाए झूठे और दिल अपना टूटे।
सोचा था रिटायरमेंट के बाद अपने घर जाऊंगा, पर पूरे पैसे भरने पर भी समय पर घर नहीं मिल रहा है। ऊपर से बढ़ती हुई महंगाई का हवाला देकर तय की हुई रकम से ज्यादा वसूल कर चुके हैं। ये तो सरासर धोखा है ना जी।
ब्रिगेडियर साहब कंज्यूमर फोरम गए। फैसला ये हुआ कि अदा की हुई रकम पर बिल्डर सालाना 12% ब्याज दे और कॉन्ट्रैक्ट के मुताबिक जो सुविधाएं नहीं दी उसके बदले वो पैसे वापस करे।
जागो ग्राहक जागो।
Welcome back. Well, Ms. Ghosh, the fact is that 80% of doctors are in urban areas, but not all of them are in the public health system. So the Planning Commission had some interesting suggestions on how to, bring more private sector doctors into the public health system. Would you say that that's a feasible idea?
Well, it is, but
some sort of outsourcing model.
More than an outsourcing model, I think what is required is to incentivize doctors who are, one is compulsory rural posting, but then again you'll only have fresh pass outs going to rural areas where even if they are MBBS, where again you have that debate coming in of why should your urban areas have better doctors than rural areas. But on the other hand, if you start incentivizing doctors who are willing to work in rural areas, maybe you will get more people. But I think one thing that has happened consistently in this is that there's a very powerful lobby. Even the health minister has said this, that there is a very powerful lobby among doctors who are not willing to make these changes work.
Right.
So that has to be countered.
But according to what Ms. Gupta is saying, that NRHM is successful largely, even though there aren't too many doctors in the rural areas. So I mean, it's really trying to replicate that model as a successful model here in the urban areas, and to bring some of those doctors in with from their private practice into the public space.
See, one thing about when you measure NRHM success, you have to understand that the levels from where you started in NRHM are unlikely to be the levels where you will start in your urban areas. You would have better, so it's easy to go from 0 to 10, but it's harder to go from 10 to 15 maybe.
Okay.
So there, I think that is one thing. And more importantly, doctors, even when they are posted in rural areas, there are cases galore of doctors who are posted, they get the salaries, but they're not there.
Okay.
So there are a lot of issues in that also. There has to be proper monitoring and incentivizing, maybe.
Right.
But one thing I also wanted to say about this out-of-pocket expenditure is that there is a lot of this out-of-pocket expenditure is of drugs, and drugs are an extremely unregulated thing right now. You go to a standard retailer and you will see him selling drugs at 50% of the MRP, expensive anti-cancer drugs.
Okay.
So why are pharma companies allowed to get away with that kind of pricing? It's not the health ministry's purview, but that's one of the important problems in our health regulation right now, because drugs are so important, but drugs are beyond the health ministry.
Okay. So are drugs, are the costs of medicine, so exorbitant that the government has to supply them free, or I mean, it should be only targeted to BPL households, that what the Prime Minister was talking about, free medicines, or I mean, in public health centers, just to bring people in because perhaps not too many people are apparently coming to public health centers, that this is an incentive to bring them there, is what the argument is.
No, actually, as Avantika said, the cost of medicines is very high. If you really look at the total expenditure, health expenditure that is incurred by households, you would find that 72% of that out-of-pocket expenditure is made on drugs alone. And if you actually look at indoor-outdoor sort of ratios of expenditure, you would find surprisingly that indoor, that is hospitalization, is about 24%. So 76% really is outpatient, where people need to go to the hospitals for consultation outdoor.
Right.
And and 72% of health expenditure is on medicines. So therefore, if you are able to actually take care of that expenditure, then it is a huge relief that you are giving to people. And also there is another factor here, that when a prescription is made by a doctor and a common man goes to the chemist to buy that, the prices could be very, very high. Whereas if the government is procuring medicines which are generic medicines, and I would say that I hope that the difference between generic medicines and branded medicines is really clear, because branded medicines are patented drugs, where the costs are very, very high. But the same formulation, the active ingredients are the same, pharmacopoeia is the same, and so then you have generic medicines which are so cheap and cost effective.
Right.
And therefore,
but there needs to be an awareness on these drugs that are
no, but the point is that if a prescription is made by a doctor,
right,
and a person has to go to the chemist, then clearly he has no option at all to get a generic equivalent. But therefore, as I said, because 72% of your health expenditure is on drugs, therefore the whole idea now is to make sure that there is universal access to free medicines, essential medicines, in public health institutions at all levels, be it sub-centers, primary health centers, community health centers, subdivisional hospitals, district hospitals, so that people actually can heave a sigh of relief, and it's a
right.
major
and what sort of a
benefit to
cost
them.
burden would this incur on the entire scheme? Bringing in free medicines.
See, the estimation at the moment is that it would be about 5,000 to 6,000 crore a year. That is the very, very rough initial estimation. That, as I said, when you are actually buying medicines in bulk and you are buying generic medicines, then clearly the costs come down, for the state governments. So therefore, but the projection is that easily, per capita sort of costs, OPD
Right.
costs could be in the range of about 20 rupees or so. So our rough estimation at this point of time is that it could cost about 6,000 crore rupees a year.
Right. Well, Mr. Ghosh, the fact is that NRHM is a success largely because of these ASHAs. Now, they're not doctors, they're just facilitators. In the urban areas, there's the talk of USHAs. You think that they could do the same sort of work? Is it possible? Because here we have lots of doctors as well, right?
Yeah, but even then, when for people who cannot reach doctors in time, and if you save that amount of time in getting to the hospital, that is a huge health benefit. And
Right.
it could sometimes mean the difference between life and death. If there's a person who's trained in doing the first aid bit or the immediate response, whatever it is, if that person is trained, that could still make a lot of difference. And I think that's a great idea.
Right. Ms. Gupta, are we focusing too much on these facilitators, the ASHAs, the accredited social health activists, rather than doctors and the real qualified personnel? I mean, is it a piecemeal, half-baked sort of a solution, is what I'm saying?
No, actually, I think their role has to be appreciated, the role of ASHAs, because ASHAs are not, it is not task shifting that ASHAs are doing or trying to take on the role of the doctors. ASHAs are actually community health workers, and basically they act as an interface between the community and the health system. Because as you would be aware, health outcomes depend a lot and are driven by other determinants, which we call social determinants of health.
Okay.
So when you look at rural areas, then you would have populations that suffer from poverty, that suffer from illiteracy, lack of education, lack of awareness, poor access to sanitation, water, things like this. So what happens is even health-seeking behavior in many cases is very weak. So what ASHA does is actually
Right.
spread awareness, heighten awareness, and then strengthen health-seeking behavior and facilitate the community to access health system and health facilities. So she is a kind of an interface, and
Okay.
she's from the community.
Fair
She
enough.
resides within the community, and she's not an employee or a worker who's getting a salary.
And she can also be
She is
distributing the free
only as
medicines in the...
No, I think the whole idea of free medicines is that it is hospital-based
Okay,
supply
fair
of. So a person comes into your public health facility and is seen by a
Right.
doctor. So it is not a distribution of free medicines. I
It
think
is
I need to
prescription.
clarify
It's a
this,
prescription-based
that if a patient comes
Yes.
to a PSC or a CSC or a hospital,
Sure.
is seen by a doctor, then the doctor prescribes a medicine, but rather than going to a chemist to buy that medicine is provided to the patient from the hospital free of charge.
Okay.
That is what this scheme means.
We need to take another quick commercial break. Do stay with us. There's still a lot more to discuss.
मिस्टर और मिसेस शर्मा ने कार ली लोन पर और किश्तों में चुकाने का वादा भी किया। कुछ दिन तो अच्छे गए, पर जब मिस्टर शर्मा किश्त नहीं चुका पाए तो बैंक ने उनकी कार जब्त कर ली, और जब मिस्टर शर्मा किश्त चुकाने गए तो
आपकी गाड़ी तो हमने बेच दी।
बेच दी?
सॉरी सर।
जब वादे हो जाए झूठे और दिल अपना टूटे।
शोभा, उन्होंने हमारी गाड़ी बिना हमें नोटिस दिए बेच दी।
शर्मा जी कंज्यूमर फोरम गए, वहाँ फैसला ये हुआ कि बैंक उनको 1.5 लाख रुपया यानी कार की मार्केट वैल्यू और जब से कंप्लेन लिखवाई है तब से अब तक की रकम पर पूरे 9% ब्याज दे।
जागो ग्राहक जागो।
Welcome back. Well, Ms. Ghosh, to what extent can, alternative systems of medicine be brought into the entire scheme of the National Health Mission? Like Ayush, which is a separate ministry and department, I think, so separate department. So how does that, is that going to help? Because there may be a lot more practitioners there, and it's also probably more affordable.
It will help, but the problem is that even our populations have become very used to allopathic medicine, and practitioners of alternative systems of medicine sometimes, because of the demand or whatever it is, sometimes do end up prescribing allopathic medicines. So there should be very strict regulations. Over-the-counter medicines are all right, but medicines which are prescription medicines cannot be prescribed by people who are not qualified to do so. But what happens, it happens even in the city of Delhi, and I'm sure it happens much more in smaller towns, is that because you save on the money of going to a qualified doctor, you go to an alternative practitioner and he prescribes an allopathic medicine which he's not supposed to prescribe.
Okay.
So that can only be brought in if there is very strict monitoring of this. Otherwise we are playing with fire.
What about the system of insurance as well, in terms of payment do you think that, that is a successful model that we can copy from, let's say, from the US or something?
Well, we have a model in our own country, which is Arogyasri in Andhra Pradesh.
Right.
And what it has done, basically, it has shifted the focus completely from primary care to tertiary care. There are reports of many more surgeries happening than is required. And what started in 2007 with a 50 crore budget has now gone up to 1400 crore, which is 50% of the total Andhra health budget. That is not doable. And increasingly, that is another issue here.
Okay.
We are putting the onus of primary and secondary care on government and tertiary care because it makes money on the private sector, which is putting unnecessary pressure on the government. The private sector needs to be regulated.
Okay. So finally, ma'am, to what extent can the private sector be regulated?
I think let me just first touch on this mainstreaming of Ayush that you mentioned. I think mainstreaming of Ayush is a very important focus area for us under the mission. And in more than 15,000 facilities, we have actually provided Ayush services under the same roof, with allopathic facilities. And more than 11,000 Ayush doctors have been engaged under the mission. Now, there are two things that you are looking at. One is that, prescription. Which is, and there is a huge demand for Indian systems of medicine. Homeopathy, for instance, is very popular.
Right.
So is Ayurveda. Also, in certain parts, Unani and Siddha are very popular. So what we are saying is that we must provide that option to people.
We seem to be running short of time, so if you could touch on that final subject about whether the private sector can be, regulated.
I think the need for regulating the private sector cannot be denied.
Okay.
And I think that it is only a very strong regulatory framework which would make sure that there is no exploitation or there is no abuse of the trust that is reposed.
Thank you very much, ma'am, for being with us. Thank you very much, Ms. Ghosh, also for being with us. Well, that's it then. Many workable institutional mechanisms, have been created under NRHM. Also, more persistent demand-side pressure groups and activists could further fix problems like possible financial misappropriation by demanding results. Lifestyles and problems of urban and rural areas may require different solutions, but a population of 1.2 billion people not having access to affordable health care is a recipe for disaster. Also, accredited social health activists or ASHAs and urban social health activists or USHAs, they are facilitators and not doctors, and we can't be too dependent on them. There are no half-baked or piecemeal solutions to problems of addressing infrastructure and manpower constraints in these matters. But these need to be addressed for any public health scheme to be a success. We leave it there. Thanks very much for